Good afternoon. Welcome to UMAT TV News Updates. My name is Kemal Erkan. This is United Medical ACO, our weekly updates. Today is January 6, 2023. As usual, we are going to have our COVID-19 updates and a lot more related to COVID and the flu season. And also, we are going to have an RCM update, and one of our client managers is going to join us. And then we are going to go into the global and the U.S. economy issues. So before I make this any longer, so I'm going to have Sean join me. Sean, how are you doing?
Doing well. How are you?
Good. So
Here I am.
go ahead.
All right. So to begin, we have our COVID updates. Number-wise, we are looking roughly the same percentage increase as the past few weeks. As a reminder to everyone, at the end of the fall of 2022, the CDC stopped reporting on these case numbers as frequently as they had been in the past. So the number that you're seeing here are delayed a little bit. It's usually about 2 weeks or so now on average that they're getting these numbers caught back up. Which is actually a good sign, because having the numbers go down means that there's less cases. And then on top of that, the mortality rate that we're seeing is a lot less compared to a year ago. So on some of the slides here, you may see the death rate compared to the winter of last year when the Omicron variant was very rapid spreading. So back then it was over 20,000 death toll in that winter, but now it's looking at less than 5,000. So obviously comparing that, a fourth of the death toll to a year ago is a significant improvement. On top of that, we also have our flu reminder. I know it's January now. Surprisingly, the temperature is a lot higher than it normally is, well above average. So the other day it was over 60 degrees, very surprising for January. But still, regardless, everyone should be taking the proper precautions, making sure that if they're feeling down, run down under the weather, maybe distance yourself from other people. Take a day off if you need to rest, recuperate, make sure you're in your best health as possible. And then also want to touch on the monkeypox numbers. We had been reporting on that. It was the summer of 22 when it was at its peak. It was around the end of July, beginning of August, it was at its peak. And since then it has exponentially decreased. And now we're actually looking at, it's around 3 to 4 cases a day being reported. So with that, it seems like it's, I want to say eradicated completely, but the numbers are very, very low. And they seem to be consistent now over the past 2 to 3 months or so of having single-digit cases on the daily average. So it's actually a good sign there that we saw it peak in the summer and it had declined since, and now it seems to be under control. No new variants on that compared to the news that we have on the COVID, however, is that there's a new subvariant of the Omicron, and I believe it is called XBB 1.5. And apparently that's actually spreading a lot more rapidly compared to some of the other previous variants of the Omicron.
So pretty scary looking one, right?
Yeah, so it says it kind of
like the image of it.
Yeah, they have the image of like these suction cups that it's going to latch on. But as with all viruses, as they mutate, become more and more aggressive and easily spread compared to as they're evolving. So the goal for the virus obviously is to survive. So it becomes more and more aggressive, so you could say. So with those, it looks like over 40% for today. This is as of yesterday's numbers, but on the one-day case.
So I'm going to interrupt you for a second
Sure.
with the year-to-date update on the COVID. So then, because I do have a couple other items on the COVID-related stuff. So we were sharing our comparison, the hospitalization numbers, and today my mouse is a little bit acting up. I don't know if it is. The computer is a little bit far, and I cannot. Okay, so I think I got it. So what you see here is this is this is an independent data. In 2021, this is November and December, so we had 4,157 total hospitalization, and from the similar I was going to say same and similar, so I got a new word. So from the similar population, we got almost 4,900. So in 2022, so this increase from here to there is about 18%. So now this is why I want to actually just have this and then go back to the discussion. So although things may be under better control, the hospitalizations are not. So we have 18% more hospitalization than what we had before for the 2-month period of 2021 and 2022. So that's a pretty significant number. So we want to make sure that people understand what that is. Now, we try to explain the issue with China, and then I do want to kind of take that a little bit slowly and then just go through that process once again. About 5 weeks ago, we got very disturbing videos from China. This is very heavy-handed police. They were going into people's home and trying to enforce the zero COVID policy. Then what happened? We said, well, like, what are they doing? What's happening? All that, like the Western style, we were just criticizing them. Then one day they reported 37 million cases from a single day, 37 million COVID cases. Then next thing they did is they actually loosened up their travel restriction.
Right. Yep.
So, and then they stopped reporting their cases.
Yeah.
So anyone with IQ 90 can add these up together and then see, okay, well, this is not looking good, right? Okay. And well, Sean's IQ is much more than 90, hopefully, right? So like, people should be able to understand this. So they are not seeing this. So our issue is like, why do we have to just repeatedly say the same thing? Is because, well, same thing are happening, but then also there are some new stuff happening. So we should be able to see what's in front of us. It's we're having a really probably problematic time. And then now China is not happy with us because we are putting travel restrictions for people who are coming from China. Yeah. That's only for a couple of countries so far. So this becomes a pretty problematic issue again. Yeah. So,
and I think just following on that, as you're saying, trying to learn from the past. Obviously, COVID was a novelty when it happened in 2020. Obviously, it's similar to other past viral pandemic type things. But in that particular sense of, it's the first time we've seen something like this to this type of magnitude, what are we going to do? Everyone had different approaches. Some had, I think back to, I remember the videos of people in Italy where they were locked in, their government said, no one go out for any reason. In the US, you had martial law where it was, only emergency first responders. So that was back when we initially had it in 2020. It's like, we don't know what to do. Here's our initial, trial response. But now, years later, we're seeing what precautions are effective, what measures need to be taken. Can we now, get ahead of it in the future? So these other variants coming along.
That's exactly what we are trying to say.
Yep.
And hopefully people will watch these and then maybe will be more knowledgeable. All right. So now, since we have our CM guest, I'm going to let her in first. And Katie is our frequent flyers on this show. So I'm going to put Sean back in the waiting room. Katie, how are you doing?
Good, how are you?
Good. Thank you for joining us. It's always good to have you. And we learn a lot. We share a lot, and I know that you are one of our big supporters with most of the other different projects that we do, and then for being part of this event also is a big support for us. Thank you. So we are going to talk about risk score and the corrected claim process that works with the risk score. Now, I just use the risk score that's very kind of like randomly, but We are going to go into the explanation of what risk score is and how the RCM actually is working directly with the risk scores, how the old-fashioned billing is no longer the case for RCM companies, all the formerly known medical billing companies. This is a different game, and this is why we want to make sure that we share new updates, not only with our patients and others, but also with our employees. So we are gonna have you present directly from your computer. So I'm gonna make you a co-host, so that way it's gonna be easier.
All right.
I'm gonna look for a mouse here, so hopefully, and this time is listening. All right, you should be able to share your screen.
All right, and bear with me. Let me make sure that's going to let me go ahead and do that here. And I do apologize. I had to switch laptops at the last minute, so I'm just trying to make sure I can pull that up here.
That's right. I have it ready here. So if
yeah, would you mind pulling it up for me? Because I don't think I'm going to be able to do it. I apologize.
So what I can do in this case, that I can give you control and see if that's if that runs smoothly, then we can do that. So it is. Can you help me here? No. So request should be right somewhere here.
I just focus mode now.
Okay, so
that's the recording.
All right, so fine. Then I'll just I'll be your mouse and the keyboard.
Okay. All right. Sounds good. All right. So like you said, this is just going to be our billing update session, but we're going to talk about the RAF score and what RAF means, what HCC means. So my name is a little bit different than the last time that I was on here. So we can go ahead and go on to the next slide. All right, so HCC, RAF scores, and corrected claim. Most likely not going to read everything on this page here, but HCC's hierarchical condition category coding and risk adjustment factors. So we see HCC and RAF, but essentially they're just phrases that are going to describe medical codes that are linked to specific clinical diagnoses. They're originally designed to estimate future health costs for patients, and along with demographic factors such as age, gender, insurance companies use HCC coding to assign patients a risk adjustment factor or RAF score. Using algorithms, insurances can use a patient's RAF score to predict costs, and it's helpful in predicting healthcare resource utilization. So what essentially that is summarizing is that, like you said earlier, we're going from fee for service where you bill a claim, you bill a charge, the doctor gets reimbursed from that, and we're going to base payments more off of these categories, more off of these diagnoses and conditions. So it really takes a shift from just performing a service to the quality of service that's actually being performed. We go to the next slide, please. I can't hear you, Kemal, here. Okay, looks like we're having some issues, so one moment. All right, so we do have this next slide here. So this explains the RAF corrected claims. So our care coordination department is a team of nurses that routinely conduct pre and post visit chart audits to identify the missed HCC coding opportunities. Our billing team ensures that corrected claims are submitted with updated diagnosis codes. And then this ensures that patient risk adjustment factor scores are updated in the insurance system to appropriately reflect their risk. We did just end 2022, but I didn't have the numbers available. So we did say that in 2021, over 5,500 post-visit audits ended up requiring a corrected claim. So what this is saying is we have a whole team of nurses that are going through these different charts, these different dates of service, and they're looking for the opportunities where maybe a diagnosis wasn't quite coded up to par. Not that it wasn't a right diagnosis, not that it wasn't the correct condition, but really we want to be as accurate as possible. I gave a little example of, you could say that you bought a new car, but did you buy a new Tesla? Did you buy a new Hyundai? Did you buy a new Honda? You need to be specific about what you are doing or what you're purchasing. We also have that little graph there that just shows you the trends through the months and through the quarters. So, whoops, we're good to go on to the next one. Thank you. All right, so capturing the risk. This is a really great graphic that explains what we're looking at here. So on the first one, you can see that we have our pretend patient, age 68. We have their demographic factors, and they have a couple different diagnoses. So they have diabetic polyneuropathy, they have morbid obesity, and they have congestive heart failure. When you add in those chronic conditions of diabetes, hypertension, and BMI, you would get a risk adjustment factor of 0.427. So each one of these issues is categorized differently. So diabetes is in a different category than obesity, is in a different category than heart issues. So each of these has a metric assigned to it. And so diabetes plus hypertension plus obesity equals a risk adjustment factor of 0.427. However, after we looked at the chart, the same patient, same visit, we took an analysis and we looked at it a little bit harder. We see that the patient has diabetes, but we were more specific. Rather than just saying hypertension, when you have hypertension with polyneuropathy and morbid obesity and congestive heart failure, this actually exponentially grows. So when you add all of these conditions together, maybe one of them in and of itself wouldn't be awful, but together they add up to be a higher risk score. So when we actually correctly and accurately code all of these, we get the risk adjustment factor of 1.325, which is a lot higher than that previous 0.427. If we can go to the next slide here, it'll explain a little bit more what those numbers mean. So here I have an example of a patient and that we reviewed, and the diagnoses, all the HIPAA has been removed. But you can see that originally the provider billed 6 diagnoses on the claim. So we have our Z00.00, our E11.21, E78.2, I10, N40.0, and N18.6. You can see as we go somewhat across the screen that there are the RAF scores affiliated with it. So type 2 diabetes is a RAF score of 0.318. Hypertension, chronic kidney disease of stage 5 is 0.237. So essentially these numbers, while they don't seem like much just in the original, I can spout out any number that I want. This is a predictive model to the insurance that the higher the number, the higher the patient is likely to have medical issues, the higher the cost is going to be, not only for the patient, for the insurance, for the facility. Basically, the risk score is determining how much money is this patient going to cost any sort of system. And what our team is doing is we're really making sure that this risk is appropriately identified. This patient was the same before and after we did our analysis on it. The difference is that when we add in an additional risk, we're appropriately telling the insurance, hey, this is a bigger risk. This patient has more issues than, maybe another provider has presented. And so therefore this patient may be needing more care. For this one, in the original 6 diagnoses, 2 had a RAF score. Other ones were just regular diagnoses. But we also saw that, like I mentioned on the last page, when there are multiple conditions, it can cause compounded issues. So you can have hypertension, You can have kidney disease, but if you have hypertension while you have kidney disease, that's a greater risk. The systems working together or not working together provide that risk score of that 0.237 that we're looking at here. Go to the next slide, please. So how do we optimize this? Teamwork is a huge thing. Obviously, my department is the one that's billing these back out. So the nurses, our care coordination, they're the one who are identifying these based off of the office who's coding these. We all have to work together to submit this. Like Kemal said, the billing companies, we're not just billing these charges out, we're making corrections. And it's not just about the fee for service dollar amount anymore. It's really about the reported quality for the patient. And the insurances are pulling this quality metric based off of the diagnoses that we're billing. So we have to have a solid understanding of HCC and ownership at all levels, from the provider up until the person who's correcting these claims. We need to do training as needed. Really, we need to also start at the beginning of appropriate diagnosis coding at high specificity. So if we recognize that the patient has these compounding problems, we want to make sure we're getting that from the start. Supporting clinical documentation, effective data management, and effective flow management all work together for this. All right, and the importance of optimizing risk score reporting. So all of this, and I've mentioned this a few times now, but all of this comes together really to improve the patient's care and to increase the revenue and increase the staff satisfaction. So this isn't just about if we code higher, we get more money. It's not about the idea of just submitting these claims for a fee for service. When we're able to correctly identify the risk that this patient poses, we're able to provide that care. And through a shared ACO, through an integrated EMR, these providers are able to talk to one another. So the cardiologist can talk to the pulmonologist and the nephrologist, and it really is able to increase that care and that communication. We have an example here of the monthly and yearly primary care population-based payment. So rather than that fee for service, that 70 whatever dollars that we get for the office visit, we now see that the insurances are going to share savings. So they present the fact that if you can share, or if you can save so much money by providing better care, then that's what the point of the ACO in this is, that they're going to share that savings. So when the risk score is under 1.2, it's $28 per member. Times 300 would be 8,400. But when the risk score is higher, you can see we went from $28 to $45. So just by making that one little shift, maybe identifying that one diagnosis, maybe that it's a obesity diagnosis or a mental health diagnosis, anything that has that RAF score, we shifted our monthly population-based payment from $28 to $45. And that's a huge increase, which you can see adds up in the yearly rate. All right, that was it for me.
All right, so Katie, so what we shared is what we know, like our core business, revenue cycle management, right? So, and main part of this is the physician compensation. So physician compensation is no longer like it was in 1967, right? So I use the, and every time I have some old days, I use the 1967 reference. It helps me at least. So in the old days, physicians were not on the cost side of the equation. So they didn't even know what patient costs, or do they even care? Because that was not how they were paid. So how we are paid from the compensation standpoint for physicians is a lot to do with the value that we actually generate, value-based contract that we work with. So then this standard fee-for-service agreements are no longer effective. They're inefficient because you just go by like number of patients you see, but how you see them is important. What you do with the patient is important. And in some cases, patient doesn't actually have to really just come to the physician and tell everything about what's going on with them. Sometimes we really need to bring up issues that they may be not sharing with us, and that's part of the value. Like, this is how we are going to be able to have an effective way of being proactive. So, like, everyone can be proactive, but there has to be an efficiency in that proactiveness. So, if I'm not efficient, if the outcome is not going to change, you can be proactive. So, this means you have to engage with the patients, and engaging patients. I just want to give you an example, and you are on the RCM side of it. So, as you know, I do daily case conferences with our ACO team and also our bariatric team. So, with the ACO team, we see issues with patients maybe not sharing. Like someone who may have hemorrhoid, they're not telling their doctors that they have bleeding, and the doctor is not making certain orders based on that. Or an elderly who's shy, maybe, to tell the doctor that they have urine leakage, and then they're not able to, if we are not actually kind of going into the details with the patients, we are not able to find these issues ahead of time. And these are not only not just from the cost standpoint, but from the quality standpoint, it's extremely important. So we know that we have a lot of elderlies around us, and if they're not able to get this help, it's gonna actually it's gonna make everyone's life a little bit more difficult. Now, the risk score is a really good way of communicating our issues, our findings with the insurance company. So that way, when we do our job very well, then we can actually demand better compensation. And this is the model that United Medical ACO is focusing on. Now, the big difference in the old days, we were just focusing on how much we are collecting for each of our clients. But today, that's not enough, because that is now tied into how our clients are billing. Do they capturing all the diagnoses? Do they go to the highest specificity of the diagnosis? Do they see the patients frequently? So the patient needs to be seen. Most Medicare patients, they need to have, if they don't have any issues, they should be seen twice a year. And this is based on Medicare guidelines. So do they get their routine checkups? So this is a different ballgame now. So in the old days where we used to be just a medical billing and the EMR company, today we are a clinically integrated group, and our revenue cycle management adopted the changes that we have, and you guys are a big part of loss opportunities. Like your team, you guys are able to work with our nurses and care coordinators to help our physicians to capture what they have missed. And because today we cannot miss these incentives anymore, because they are no longer incentives. I always say this, and people don't understand what I mean by this. Incentive is something that you get extra, but if this becomes part of your compensation, that's part of your total payment. So incentive is you get your total payment and then you get an incentive. That's different. But today's world, value-based contracts are part of our main compensation. So,
like the medical Maslow's hierarchy of needs. Once you meet the base requirements, then you're going to be building on that. And it's really interesting too, because the diagnoses were the foundation for it. So we've always used diagnoses to build the claims, but now we're building quite on top of that. So it's a really neat foundation and kind of a pyramid to look at in that way.
Absolutely, absolutely. Well, I'm hoping that these sessions are going to help our employees who actually just join us, and we are actually using these for our trainings as well. Not like the main training resource, but as a support for our new hires. And in some cases, our well-established employees, they do need to hear these in a different way in time to time. So then it actually makes their understandings much better and much more clear. Well, Katie, it's always good to have you, and thank you for joining us today.
Yep, thanks for having me. Have a great day.
Bye-bye. All right, Mr. Dunnigan, welcome back.
Thank you.
We had a little technical crisis here, but I think we managed it. So I may have a little bit issues with my mouse, but I think we'll be okay. So we are gonna go into the global events. So last 2 weeks, we've been discussing the issue of climate change. Climate change is, I mean, at this point, when we look at everything that we discuss, what we are doing and why we are doing certain things. So climate change is real. So we are not questioning that, right? Our issue is with the plan of actions that's been taken in place. Most of these plan of actions are not only extremely costly, but also very ineffective. Now, we discussed in the last 2 weeks, we discussed in detail what we meant. There is a video that I'm going to play after you give us some background on this. For example, in Florida, we were focusing on Pakistan and India, and I got some messages from some of our doctors, and they're like, why are you like using our country? I'm like, I'm not using your country. So this is, you know, this is the obvious example. So, and then we actually added Florida even before that. Yeah. And what's happening in Florida is a little bit different because climate change, we were kind of tying that into the poverty and the population growth in the poverty. So when I'm looking for that video, I know you reach out to some people. We are lining up some guest speakers coming in.
Yeah, so just to recap everyone, as Kemal mentioned, in the last 2 weeks, we did focus the majority of our sessions on climate change. And as you said here in our intro, it's not that we're denying or saying it's not a real thing or anything, but we're kind of trying to focus our session on it's the approach and the end goals that are set in attacking those climate change as an issue. And that's what we're trying to evaluate, break down, analyze, and see, as you're saying, are they going to be efficient? Or is this end goal where even if we reached all our benchmarks along the way, we would still fall short in actually combating this climate change problem to begin with? So what we're trying to do here is break these down and kind of see what areas need to be paid a little bit more closer attention to, what areas maybe people are shining the flashlight on a little too much, and they're saying, oh, you know, climate change, this is what comes to mind, this is what the entire issue is about right here, whereas it's only, in reality, maybe it's just a little tiny factor in this bigger issue of climate change. So if we're talking about our population density and those examples that you were just saying with India, Pakistan, and Florida too, just to remind everyone from the last week's sessions how I think the example, the analogy I used was if you're at a water park and you're sitting in the splash zone, and then after the show goes on, you're somehow shocked that you got wet while you were sitting in the splash zone the whole time. What were you expecting? So that's kind of relating to the infrastructure issues that we touched on.
So absolutely. So, and I have the video. So let's let me actually play this, and hopefully it will have a good sound. And you need to help me because I cannot see. I need to make you co-host.
Make co-host, yeah.
All right. So let me share what I'm looking at right now. And then if my team can actually give us a feedback on the sound. So it's not on there. So
people who can afford it and trainers. But climate change is the future of
tranquility of the ocean. But climate change is putting the future of that property at risk. The planet has warmed 1 degree Celsius in the last 30 years, and sea levels are now rising at alarming rates.
It happens for two main reasons. The first is that there's more water since the land-based ice is melting, and also as water gets hotter, it expands. So we've seen over 8 inches of sea level rise in the last 100 years.
A new study. People who can afford it are willing to pay more for the beauty and tranquility of the ocean. But climate change is putting the future of that property at risk. The planet has warmed 1 degree Celsius in the last 30 years, and sea levels are now rising at alarming rates.
It happens for two main reasons. The first is that there's more water since the land-based ice is melting, and also as water gets hotter, it expands. So we've seen over 8 inches of sea level rise in the last 100 years.
A new study by the Union of Concerned Scientists is looking at the real cost of chronic inundation, which is flooding that happens at least 26 times a year.
So by the year 2045, so less time than it would take to pay off a mortgage if someone bought a home today, there are over 300,000 properties throughout the lower 48 that would be experiencing chronic inundation. That number jumps to 2.4 million by the year 2100. Those 2.4 million properties, according to today's values, are worth over $1 trillion. And Florida is a state that is most at risk for chronic inundation and the impacts of sea level rise in the lower 48. We actually represent 40% of the risk.
What can be done? Is there hope that we can actually stop this and fix it?
That's actually the really great piece of news that's coming out of this report. We found that if the U.S. stays in the Paris Accord, if we adhere to that agreement, then the majority of the properties at risk in Florida would be spared the worst. So we can take action, but that.
All right, I hope you guys were able to hear everything. So let's put this one back in the okay. Oop. All right. So this is where the problem is, guys. So if you heard what she said, and I'm trying to kind of keep certain language in these sessions, but I don't know anything other than just using stupidity for her opinion on this whole issue. Because what she's saying is she's describing the issue in Florida and not focusing on the buildings, not focusing on who's building, where they are building. And she's saying that the Paris Agreement is going to actually fix this. You have to be so stupid to say that.
Yeah. Just to remind everyone, the Paris Agreement, with its goal of combating climate change, I believe it was 178 countries globally had to agree to this. And the contributions, I know we touched on this last week and the week prior, but the contributions that are being expected from all of these different countries who, I mean, you have first world countries, which are, economic superpowers in this agreement, and you have other countries whose, GDP is fractional of some of these other countries' superpowers. And you're kind of asking everyone to match this universal threshold of use and, reduce, reuse, recycle, kind of manage their eco footprint, as you would say. And the fact that even if, we looked at some other studies here, even if all the countries did hit their benchmarks, which number one, as I just mentioned, that's kind of unrealistic to begin with. But even if they did, the impact actually wouldn't help combat climate change as much as people are actually anticipating. And I think one of them said that even if all the benchmarks were hit, it would still be less than 1% of the actual goal of reducing the global temperature, but I think it was 2 or 3 degrees Celsius, maybe
1.5.
1.5.
Sean, the problem is with the idea of Paris Agreement, it actually focuses on most developed countries actually financially supporting less developed countries, because this issue last week we discussed that there's no real border, physical border.
Right. One atmosphere.
Yeah, it's one atmosphere. So then, but this issue, Florida is different. When she's putting Paris Agreement in front of us for climate change for Florida, then we know that these people are clueless. Now, again, I promised Dr. Erkan that I'm not gonna be too opinionated on this issue until we have our experts when they show up. So, but every time I'm actually getting into this more and more, it's difficult. Difficult in a way that no one is questioning why did we build, like she just said in that same video, 1.5 minutes, she said the total worth of the buildings is 1 trillion. Like how much is being built?
In the splash zone, yeah.
In the flood zone. So now no one is saying that don't build it, that don't build here. So this is that simple.
Right.
It's what we know is climate change is inevitable. So the focus has to be on the most effective methods. It's not going to be like, okay, we are going to build the most, the highest high rises, then right on the beach. We are going to build right on the riverbanks. And then the most vulnerable population in poverty zone, and there we are not going to actually help them to educate on birth control in this case, because if you remember the numbers, the total growth in 60 years in just one country is 1 billion in India. 1 billion. And the other country next to that is 400%. In poverty, this is happening in the riverbanks. So the damage is right there. So we know that we need to move away from those places. So then then we are talking about hundreds of millions of dollars, billions of dollars every year to finance these things. Who's going to actually pay that?
Right.
Not knowing it's going to be effective.
Yeah, and thinking about that money too, like with these buildings, saying billions of dollars, where maybe everyone's saying, in some of these countries, we're building close to these river because it's source of transportation and goods and shipment and everything. But maybe instead of having the money go towards like these relief packages for when disaster does hit, you have to then go do these rescues and rebuilds. Maybe just put that money and say, all right, it's going to help fund, irrigation systems or transportation, so we can actually build in an area that's at less risk, but it's going to cost to transport this stuff a little bit further inland as opposed to building around these water. Maybe put the money towards those type of approaches as opposed to this rescue package of.
We should know by now. Like it's kind of easier to make fun of, not fun of, actually maybe pick on India. But if we are not making changes in our country here, then how can we expect them to do anything better?
Right.
Now, I also don't want to fund anyone's bad choices.
Well, I mean, I think at the end of the day, people do have strong opinions. This is where I want to be. Who's to tell me I can't be here? Which
What's the law?
Yeah. So maybe it's not going to be, as you're saying, 80-story skyscraper or a luxurious apartment complex type thing. So
everyone has to be on. Well, it would be nice to own one of those, but you don't have to be. Like if you can
be modest,
that's simple. So now we are not going to today. We are not going to spend too much time on climate change because we want our state officials to join us and a couple of professors that we are trying to reach out. But we are going to bring this issue back and also make people aware of these issues, so they should pay more attention. We are going to end up paying a lot more taxes if we don't control these irresponsible spendings. So someone always pays, and that usually is someone who may be benefiting from those in a short term, but then we have to look at it long term. So if we are going to pay these in our older times, like I don't want to work when I'm 78 the way that I'm working today,
Right.
just because the government made bad choices. That's that simple.
Yeah, I think that's one of the themes that we've been actually preaching in all these sessions, is looking at the long-term goals and even kind of moving away from that immediate gratification as opposed to this delayed gratification, where you're taking a more conservative approach. That way down the line you can have sustainable, and it's not all of a sudden, you know, time on the clock's running out, and you know, we have to scramble to sort of fix this, and there's, you know, we're kind of backed into a corner. Oh, it's the only option we have is to have, you know, increased taxes to get this relief package, because there's no other way, other method or source to fix a problem. So.
Absolutely. All right. So now, where do you want me to go from here?
So we do have a couple of items on the U.S. economy, which fitting as we were just talking about the financial aspect too of this climate change, and a couple other items that are more specific. I know one of them we're touching on is Amazon as a company, and the fact that they just laid off, I think it's 18,000 workers, and kind of just zooming out and saying, you know, one of the leaders in the industry, such a big company as Amazon, who it seemed like they're expanding, you know, these other factory centers all across, but now to be taking a step back, and now they're actually reducing their workforce. So what does this mean?
18,000 people.
18,000 employees.
This is, they're saying initially, right? So
their first step,
that
yes,
means-
it could be more, but we're trying to, you know, take a step back and say, what does this mean if, you know, a company that you think is such growth heavy in their industry, what does this mean if a company like Amazon is now having to downsize and kind of cut some costs, and how is that reflective of the economy and what we're seeing in the future going
And
ahead?
also, this is important for Delaware because we are one of the, I think Amazon is one of the biggest employers in Delaware. I don't know if you have the details of those numbers, like how that 18,000 is divided, but this would have impact in Delaware.
Yeah. And then another thing too is the fact of they're mentioning Jeff Bezos may eventually come and step back in as CEO. I know for those who may not be as familiar, but in July of 21 is when he was no longer CEO, stepped down, but now there's actually discussion on.
So I don't know if that means much for them, so they're always in charge.
Well, I mean, I know that he started the company, and to think that, you know, you grew this from, you know, a small baby in a garage type, you know, setting, that it's a worldwide company, and is the company not going in the direction that he saw it initially? Now he wants to re-intervene, or, you know.
You know, his divorce cost him a lot of money, so he has to probably come back and work a little bit more.
I would agree. It's clock back in. So.
All right. So now there was, did we actually cover the one that we had with the, I know climate change we were done, but there's a health impact of the climate change. Did we actually include that? Yes, right, with the respiratory health.
Yeah, so that was actually at the end of the global video.
So actually, maybe we can do that next week, because, you know, at the end of the day, this is a healthcare news channel, and everything that we do, we always go back to how this is impacting our health. Like, is it related, or is it, if it's not related? And everything that we talk about always comes back to that anyway. So,
agreed.
I know we have Dr. Erkan coming up at 3 p.m. Last week, he had some emergencies at the hospital with one of the general surgery patients. So we are going to do an intermittent diet, intermittent fasting discussion, and how we utilize that in the morbid obesity world. And our last episode was, it was getting a lot of attention regarding the people who are not experts, but then they're making a lot of opinions in these social media or the media that they occupy. So I think this responsibility of having the right resources in the right place, that's something that we owe to the public. And I believe our Bariatric Friday is doing that. from United Medical ACO and from the American Surgery Center and CHRIAS standpoint. All right, so well, this is all we have for today. This was our first episode of 2023. We have a lot of guests lining up.
Yes.
Most of them are already confirmed. Our governor, I believe on February 10th, is going to be with us. Prior to that, a couple of our state officials will be.
Senator Poor on the 3rd.
Yeah, and almost every month we have someone. So we'll be back with a lot of good updates, hopefully a lot of positive updates. So we'll see you in a bit and have a great weekend. Thank you for watching us. Bye-bye.